Hello, everyone, and welcome to the Art of IV Care. My name is Paul Weber. Now, normally you'd hear Jane Barnett's marvelously mellow voice hosting the Australasian teleclasses, but Jane is away today at some meetings, so the pleasure of introducing our speaker falls to me. Now, I am in Canada. I live near the northeast shore of Lake Ontario. This topic was originally scheduled for late last year, but had to be postponed. And I am so glad that we're finally able to introduce Professor Claire Rickard. Professor Rickard holds a prestigious Australian National Health and Medical Council Leadership Fellowship. It sounds fascinating, very difficult to say. She is a professor of infection prevention and vascular access with the University of Queensland. And after specializing as an ICU nurse and completing a PhD in infection prevention, she established the Alliance for Vascular Access Teaching and Research. And if you're a fan of acronyms, as I am, that spells out AVATAR. It's fantastic. Professor Rickard has completed more than 50 randomized controlled trials, has at least 340 journal publications to her name. She is ranked as #1 author worldwide over the past decade for literature search terms, catheter infection, central venous catheter intensive care unit, and catheterization, peripheral venous infection, venous catheter, and patient safety. I'll get this right. Her work has shaped really many of the international clinical practice guidelines, and on top of all that, Claire has a marvelous reputation as a conference speaker. To speak to the art of IV care, Professor Claire Rickard, you have the floor.
Thank you so much, Paul, for that. And thank you to Jane and also Weber Training for this opportunity. It's great to speak to everybody today. Let me just advance my slide. So you mentioned you're in cold Canada, Paul. I'm in very hot Northern Australia. So I thought you'd like to see where I'm speaking to you from. It's the yellow star there. So we're on the eastern side and the north of Australia here, and it's very beautiful. Come visit us. We have a lot of lovely beaches. We have a very big river that the city is built on. And of course, we have a wonderful history and very much respect and acknowledge our Indigenous people of the region. So this is my home team here, and I just wanted to mention them because obviously a lot of the work I'm presenting could not be done without their absolute support and great brains. So this is the Infection Prevention and Vascular Access Group here at the University of Queensland, and we are a co-partnered group in the Hurston Infectious Diseases Institute, which is in Metro North Health, one of Australia's largest health systems. So we have a large team of PhD qualified nurses and doctors and pharmacists who are working in this area. And we also have an excellent team of research students, research nurses, coordinators, and so on who make the magic happen. And we have our funding from a variety of sources, government, hospital foundations, and so on. We also have some industry grants, which I'm disclosing there. However, all of our work is sponsored by the university and is independent academic work. You mentioned AVATAR in the intro. So AVATAR is the broader network that we sit within. Let me just get the slide. There it is. So AVATAR was established in 2007, and I'm very proud of it. It's grown into a very large and very effective network of research groups. We've trained many of the leading researchers in this space in the world. We've been very lucky to partner with lots of excellent international researchers. And as you can see there, there's a lot of, especially randomized controlled trials, but a lot of other research as well that's been done to really try and make sure patients have a very safe and comfortable experience with their vascular access device, regardless of what type of device it is. So we do look at at peripheral IVs, but we also look at all sorts of central catheters and across any patient population, from neonates right through to the elderly and every patient population. So encourage you to have a look at the website. We have a very active website that has about 2,500 hits every month from around the world. We try and put a lot of free downloadable clinical practice information there, teaching videos and so on, because we do understand that people are looking for this sort of thing and they often don't have other resources. So go on, have a look, and you can also sign up for our newsletter if you'd like to get more regular updates from us. So today's lecture, I'm going to cover a few things. I want to just overall review the concept of peripheral IV catheter infections, talk about the evidence that we have for how to prevent these infections, and also just take a bit of a big picture look at the context in which our health systems try and make sure that we provide these important devices but without associated complications. So it is a long talk. These days, people's attention spans, including mine, are short. So I hope we can all bear together through this. I thought I'd start with a general discussion about infections in these catheters, then drill down to localized infections versus bloodstream infections. It would be remiss not to briefly touch on other complications in these catheters because there are a lot of them, but that could be an entire lecture in itself. And then I want to talk about the sort of infection prevention interventions we can do, both at the individual patient level, but also sort of some of the system level things we can put in place to make things safer. And of course, try and look into the future to see where we're going. If you'd like more information, a lot of what I'm presenting here is contained in a textbook chapter in this textbook, which was recently published, on which I'm a co-author. So again, just point you towards that as another source of information if you're looking for more later on. So peripheral catheters, well, I think they might be the most important and certainly the most used invasive device in hospitals all around the world. We did get the purchasing data a few years ago, and we estimated from that that about 2 billion of these peripheral IVs are sold every year in the world, which is just a staggering number. Incidence and prevalence studies in hospitals, acute care hospitals, regularly show up to even 90% of patients have a peripheral IV catheter. And we know that they're used for therapy in every medical specialty, every clinical setting. So they really touch, everyone in their life will probably have at least one or more catheters, and certainly all of us as health professionals will be familiar with insertion or care and maintenance of these devices. Now, of course, one of the trends we're seeing now, and I'll talk about this a little bit more later, is the use of ultrasound for insertion. As ultrasound devices have shrunk in size and cost, and as patients are getting more difficult to place cannulas in, increasingly we're seeing ultrasound used at the bedside to insert cannulas or peripheral IV catheters. So more patients are difficult because the average patient now is getting a lot older, so their veins are not in as pristine condition. We also have a lot more overweight and obese patients, so their veins are much more difficult to palpate or to find. And because there is a lot more intravenous drugs available now. So when I started nursing, we had a very limited supply of drugs available in intravenous formulation, whereas now there's a huge number. So the veins are constantly being bombarded with different chemicals and irritations, and often we don't realize it, but those veins are then decreased in quality and can't be used in subsequent therapy, perhaps a decade or more later. Now, it's really recommended that peripheral catheters are only suitable for therapy for around maybe a week, maybe 2 weeks. And of course, we only want to give medications or fluids that are considered peripherally compatible. If it's too toxic and irritant, the medication or fluid, it will immediately start to destroy those veins, which the therapy will then not be able to be given. So I've put a reference there. This is a very important reference that recently updates all of the evidence for which drugs and which fluids can be given through peripheral cannulas. In our hospital and many others, we have an algorithm to guide the staff. Sometimes we say that we will allow those medications to be given as a single dose if it's really, really, really urgent, but we know that really they need to get a central line in. Now, internationally, there's a bit of inconsistency with what people call these peripheral IV catheters, and there's now increasing different types of them, many manufacturers, many designs. So, the infusion nursing standards of therapy categorizes these PIVCs as short PIVCs, which are the traditional short plastic cannulas, but they're now becoming increasingly available as long PIVCs, about 10 up to 10 centimeters long in adults. And these can be used with the ultrasound guided technique. Generally, that's what they're used for because we're looking for a deeper vein. Uh, Also, this crosses over into midline territory, which is still technically a peripheral IV. Generally thought that they should have the tip exit no further than the axilla or the armpit. So within this, there's also other terminology like mini midlines and all sorts of things. For the purposes of this talk, I'm mainly talking about short plastic peripheral IVs, whether they are or not inserted as a with ultrasound guided technique. I guess I'd just mention that use is also on the way up. From the 1970s, where maybe one or two patients in your average medical surgical ward or unit would have a peripheral IV cannula, we're now seeing that, again, up to maybe 90% have them. Some data suggests every decade we're seeing a 30% increase in use. So, this is a really important area of healthcare. Now, about 10 years ago now, I was very fortunate to undertake this worldwide study, the largest study that's ever been done on peripheral IV catheters. It was ambitiously called the OMG, or the 1 million global catheter study. We didn't quite get to 1 million, but we gave it a good try. And here's a map here and just a few pictures of all the many, many people that participated in this study. So, this was a wonderful chance to really compare and understand the use of catheters, the risk factors all around the world, and to meet a lot of new friends, and also to then set priorities for improvement. So, I'm going to talk a little bit, quite a bit, about the data from this study throughout the rest of this talk. So, in the OMG study, we ended up with 40,620 PIVCs, so quite a lot. They came from more than 50 countries. It was a huge amount of work by many people, including translating all the forms into many languages and so on. And you can see there the really good spread we got of cannulas all around the world. And apologies if I keep saying cannula or catheter, even I find it difficult to keep using the standardized terminology, which is also, a common issue in the literature, but they're the same thing: cannula, catheter, IV drip, and so on. So in the OMG study, we looked at the reasons for PIVC insertion. I'm sorry, the graphic hasn't come up there, but essentially the yellow is for medications. So most of them are put in for medications, smaller numbers for just IV fluids, for a very small number for just monitoring. So perhaps an unstable patient that could potentially have an cardiac arrest. The brown part there is about 7%. There was an unknown reason for insertion, so often documentation is quite poor. A small number were also inserted for parenteral nutrition of some type. That's generally not recommended for peripheral cannulas. However, depending on what's in that actual parenteral nutrition, if it's a sort of lower dose sugar solution, that may have been what they meant by that. Sometimes PIVCs are only put in for taking blood. Generally, this is discouraged, but there could be some situations, for example, patients who have to have a sequence of repeated measures while they're having a transfusion or blood or a drug trial, perhaps. Or if they have extremely poor veins, sometimes this can be done. So, if we think about these catheters and infections, we know this can occur because we are making a hole in this patient's body and we're leaving that hole there and allowing potentially bacteria, fungi, viruses, and so on to enter. The picture there is a highly magnified needle stick into the vein taken after the cannulas come out. And you can see how, rough the skin tissue is there. There's bacteria lurking in all of those skin folds, even though we do, of course, use antiseptic at insertion to decontaminate. The skin can never be sterile, so the bacteria can just enter through that hole. But in terms of other sources of infection, About 50% are thought to enter through the internal surface of the catheter, so the inside, as we inject or manipulate the cannula, with the bacteria coming from the hands of the healthcare worker, or inside the medication, or perhaps even from the patient's skin and so on. Very rarely, but it can happen, is infection from device contamination if the packaging has been interfered with in some way during manufacture or afterwards in transit. And of course, if the patient has a bloodstream infection from another site, like the urine or the lungs, potentially the bacteria coming around in the bloodstream can then colonize the catheter itself and create an infection that way. But overall, about half of all the infections are thought to come from the skin and about half through the inside of the cannula during manipulation. So, when we think about all of the bloodstream infections that are caused by healthcare, the data we have suggests about 4 to 6% of those, so quite a significant proportion, are caused by peripheral IV catheters. We know from all bloodstream infections that happen in healthcare, about 30% are due to some type of vascular access device. Traditionally, we always thought of those as central lines, but we're realizing now that up to about a quarter of those are actually from the peripheral IV catheters. Now, I guess the headline, of course, that we would all agree with is that these are preventable infections. They should not happen, they do not need to happen, and we need to stop them happening. So let's talk about the local infections now. So local or localized PIVC infections are when the infection has only reached the local vein or the local soft tissue around the cannula. And we see, unfortunately, this happening often, that the patient complains of pain. That's the number one symptom. Redness if the patient has fair skin, or warmth at the site. That can rapidly or slowly progress to an advanced infection seen by purulence or pustules, vesicles, boils, and so on. Hopefully, we've taken it out before it gets to that point, but sometimes this develops even after the catheter is removed. So, in terms of the surveillance definitions of what we pick up in our surveillance, we pick up generally only those that don't have a bloodstream infection. So, both the European CDC and the American CDC specify that these are infections localized alone with no bloodstream infection. Otherwise, they would be categorized as a bloodstream infection. However, clinically, we know, of course, that patients can have both the localized infection symptoms and the bloodstream infection, and one can precede the other. To get a formal confirmation under surveillance, we need to either see pus or we need to see a confirmed tip culture combined with pus or combined with signs and symptoms at the site. So this can be an issue because obviously we don't always culture catheters at removal. Sometimes the catheter falls out, or sometimes they didn't have any suspicion when we removed it, so we didn't culture it. How often do the patients get local infections? So Nicole Marsh and a team of us looked at all of the published studies from 2001 to 2022, so 2 decades. We found 30 randomized studies or cohort studies, and overall, the reported incidence was 1.5% of patients with a cannula will develop a local infection. Now, there was quite a range. The majority of studies report 0%, some report 5. So because these are rare, you actually do need to see large studies to really get a strong confidence in what the incidence is. We did do a bit of subgroup analysis and looked at the data from developing or developed economies, and we couldn't see any difference there in the risk. And similarly with emergency department insertion or insertion in the ward, the rate of infection seemed to be fairly stable. So who is most likely to get a local infection? If you read the literature, the things that are often mentioned are very young patients, such as neonates, very old patients, people with immune suppression from some source, for example, cancer, There's only a couple of studies that have actually gone and rigorously looked at risk factors using statistical techniques. And here's a couple of them. So, Lee in Taiwan took 46 patients with a local infection, did some very nice matching and regression, and identified the bolded factors here as risk factors. So, I guess just calling out insertion in the lower limb, we do see 8.5 times the risk of infection if it's in the leg in an adult as opposed to in the arm. The other factors about the continuous infusion and so on really in their patient population reflected severity of illness. So the patients that were receiving more treatment, they were sicker and they were more bedbound, did seem to be the ones that had a significantly higher risk of a local infection. They did see some risk associated with lipids and parenteral nutrition. I assume that the parenteral nutrition may have included lipids, but we're not sure about that. Lipids do seem to be the only media in laboratory studies that absolutely are a great conduit for bacteria to multiply in very rapidly. A more recent study from France looked at data from 3 randomized trials and analyzed that. They found the overwhelming predictor was insertion of the cannula over a joint, so the wrist or in the elbow, the antecubital fossa, which almost doubled the risk of a local infection. Now, the thinking behind this is that even though we put a cannula in and we think it's just going to stay there, there's actually a lot of movement. So, if the cannula is in a place where every time the patient moves their arm, such as to eat or to pick up their phone or reach out for something on their bedside table, the cannula actually does have some micro movement. So, maybe only by a few millimeters, but it's moving in and out of that wound. And remembering that the wound has skin bacteria sitting there at the wound. So, this seems to be why the extra inflammation may be caused and leading to infection risk. Now, the problem is, I suppose, is that we tend not to take these catheters out as quick as we should. So, in the OMG study, 10% of those patients had red, painful, sometimes purulent sites, insertion sites, but they had not been removed. So, 10% is a lot, 1 in 10. And of course, the best thing we can do to avoid an infection or cure the infection is to take that cannula out. Here's a management plan, that a nice one that was published recently by Heng, summing up some other authors' work as well. Now, in most cases, a local infection can be dealt with just by removing the cannula. This is obviously source control, the number one thing we can do. But not all patients respond just to that. Some of them do actually go on to progress to have worsening symptoms and need far more invasive treatment. So, just calling out the study by Lee again. So, in the bolding down the bottom, Lee found that of these patients, more than half, even after their cannula had been removed, more than 3 days later, they still had a very red, angry site. And 13% of the patients actually developed an abscess and needed to have surgical intervention. So you can see that while we do sometimes manage to just take the cannula out and have a successful treatment, in oftentimes it's actually far more ongoing. So it's very important once the cannula is removed to keep assessing and documenting the site and the patient's response. If they're going to be discharged home, we need to explain this thoroughly to the patient and hand this over to if there's a treating community physician or nurse who's going to be following them up. So let's move on now to the bloodstream infections. So PIVCs can absolutely allow any sort of microorganism to enter the blood. The two concepts we want to think about is sometimes BSIs are associated with a cannula, as in patient has a BSI, they have a cannula or they've had one, and we think that that is the most likely source, but we don't actually have any strong evidence for that. The other term that's used is related. So, PIVC related bloodstream infections generally means that there is now either microbiological confirmation from the tip or from pus with a matched microorganism. So, in the surveillance definitions, we can see this here. The European CDC has 2 categories of catheter-related infection due to PVCs. In the first case, they allow for patients who either had no blood culture done or the blood culture came back negative. In these cases, if there is a positive tip culture and the patient's symptoms such as fever improve after the catheter is removed, this will be then captured as a catheter-related infection. The other category is the more stringent one, where there not only needs to be a blood culture positive, but there also needs to be a positive culture matching the microorganism in either the pus or from the tip. Currently, the US CDC doesn't specifically follow PIVC bloodstream infections and report them. However, these would be captured as a primary BSI using their usual laboratory confirmed bloodstream infection criteria. As far as a diagnostic definition, this was published a little while ago, but is still generally used in the literature to give a way of more specifically confirming the cause of the infection to the catheter. And you'll see there that it needs not only the bloodstream infection, but also the tip culture with a matched organism, as well as clinical signs of infection and no other source. So what do you do if a infection is suspected, a bloodstream infection is suspected? Well, the only thing you really need to read is the first box on the slide, which is take it out above all else. Of course, thinking about it more thoroughly, we need to do a clinical assessment, and that includes not just the current catheter and any other devices, but also old peripheral cannula sites. So, in some studies, up to 80% of bloodstream infections from peripheral catheters were from an old catheter that had been removed some days ago. Often these are missed because once they're out, we sort of often forget to document them or look at them. But we need to do the same routine that we do for the current catheters, which is touch, look, and ask the patient. Pain is a pretty specific way of ruling out infection, and redness if the patient has fair skin, but they're not terribly sensitive because, of course, patients can have these because of chemical phlebitis, irritation, and so on. If there's pus or the symptoms are tracking further away from the insertion site, this is far more convincing. Of course, we're looking for the usual signs and laboratory results that indicate a new infection. As far as microbiology, of course, we would go ahead and take two sets of blood cultures as usual. We also want to culture any discharge coming out of the catheter, and if possible, remove the catheter, not only remove the catheter, but culture it as well. So we know from the evidence that there's no benefit in culturing every single catheter that comes out, that just will get false positives and waste time and money. But of course, this is worth doing if the patient is strongly suspected clinically of infection. And just to be aware that when you're reading studies, of course, they've all done different variations of investigation their infections, different laboratory techniques. And so, just because there's negative cultures, etc., doesn't necessarily mean the patient didn't have an infection. It just may mean it wasn't captured. So, how many patients get a peripheral IV bloodstream infection? We know that rates are low, but because there are so many catheters used around the world, there are actually many, many infections, and it's very substantial. However, it does seem that perhaps the rates have dropped over time. Marsh's recent systematic review that we did suggests that the overall rate is about 0.02%, or 2 in 10,000 peripheral IV catheters gets a bloodstream infection, which is quite a low rate, but again, adds up given the number of catheters inserted. Uh, a couple of decades ago, Mackey did a very comprehensive review, and they found a 5 times higher rate at that time, so 0.1%. So, of course, a lot of other things have changed and happened over the last years, last decades, but it seems that possibly there has been a reduction in risk over time. So, some cause for hope. When you read the literature, it's really divided into studies where they have done an inception cohort. So they start by studying all patients with a catheter, and then they follow them carefully, looking forward to see if a bloodstream infection develops. In these sort of studies, you generally get a lower incidence of infection than you do in surveillance reports, where they take the infections flagged by the pathology system and then work backwards to look at the PIVC data. These incidents are generally higher because often there is no other source of the catheter seen, and so because a lot of patients have phlebitis and so on, they will often have the catheter as the source. The other challenge with this design of study is that the documentation is extremely poor in charts about cannulas. So when you're looking back, it may look like you had a peripheral IV in place, uh, for a week, but it could have actually been taken out on day 2 and nobody documented the removal. Similarly, the actual insertion itself is often not documented, and we regularly in studies go to patients. In the chart, it will say they have a cannula in their right hand, but when we go to the patient, they actually have one in their left cubital fossa, for example. One thing which we should be very concerned about is it seems incidence is generally higher in countries with developing economies. So the INIC group, led by Victor Rosenthal, has published many papers. Here's just one here, where they are finding 1.2% of ICU patients have a bloodstream infection associated with their PIVC. And even though ICU patients are obviously a sicker cohort than perhaps the patients that were captured in our work led by Marsh, it does suggest there is a more of a risk there. The other interesting or concerning aspect is since the COVID pandemic, Pianka et al. Showed that the risk of BSI and cannulas has increased almost threefold, and we assume this is due to general resource shortages, workforce shortages, and so on that we're still struggling with every day. So, which patients are at risk? Are they all at the same risk? It doesn't appear that way. It seems that many patients are low risk, but many patients are high risk. So, in Australia, this is our data from nearly 20 years of studies we've been doing. We've studied in those all prospective studies over 14,000 PIVCs, and we've only seen 6 confirmed PIVC bloodstream infections in that time. So that's about 4 in 10,000. What we do note is that we're seeing quite a number of gram-negative infections. In decades past, it was very predominantly gram-positive organisms in peripheral cannular infections. We are seeing this trend change in a number of studies. We did do some of our studies in smaller regional hospitals, but all of the infections happened in the large metropolitan centres. All of the patients that had bloodstream infections they'd been in hospital for a while, they'd experienced multiple PIVCs during that admission, usually because the others had failed, other cannulas had failed. They generally all had difficult access, so inserting was often a complicated procedure with multiple punctures, multiple staff potentially involved. Nearly all of the patients were male. They were all older patients. We haven't seen any infections in our pediatric patients to date, and all the patients had comorbidities. Interestingly, we saw, I think 4 out of the 6 had gastrointestinal procedures or drains, as well as 4 of them had cancer. We also saw the practice was a risk, with nearly all of those patients having symptomatic catheter insertion sites, so red, painful, etc., or the catheter had not been used for 24 hours or more. So it was idle, we would say. It's not being used, it should have been taken out. That may have prevented the infection. A couple of other authors have looked at this with more statistical precision in that they've had a case series and then controlled it with other patients who did not develop an infection and looked for significant risk factors. So Sasaki took 99 patients with a PIVC BSI in Japan and found that the predictors in a multivariable analysis were older patients were 3 times at risk. Patients who were able to go and have a shower were also 3 times at risk, possibly because their cannula was getting wet in the shower and the dressing was becoming moist underneath. They also had an elevated PIT score, which is a severity of illness score, and were also on parenteral nutrition. Parenteral nutrition in this study was actually a protective factor, so those patients had only 1/3 the risk of developing a bloodstream infection, and I really can't say why they may have seen that in that study. More recently, Pianka looked at this, and while they weren't able to undertake a full multivariable analysis, their univariate analysis showed us that the significant risks were patients in the ICU, so again, severity of illness, patients with a large cannula, which again, probably sicker patients having more access, more opportunities for contamination. They also found being female was a significant protective factor at again a third of the risk, and this fits with our experience in Australia that it seems to be more males at risk. So, what happens to these patients? Obviously, they have a worse outcome usually than patients with just a local infection. A bloodstream infection is a deadly infection if it comes from a cannula, just like anything else. 30-day mortality has been reported at 13% in one study, and they found that death was much more likely if the patient had an infection early after the cannula had been inserted in the first few days, possibly because they had an urgent or difficult insertion, so that was when the contamination occurred. And all of their patients were immunodeficient, which is similar to our experience in Australia. Another author, Pujol, looked at how much of this mortality was directly caused by the PIVC bloodstream infection, and they actually found that 1 in 10 cases of patients that died was directly linked to the cannula. We do see this as well in our hospitals, although we haven't picked it up in our research data to date. We absolutely have, unfortunately, seen patients die directly because of these infections. Tatsuno, another study, looked at the risk of mortality from a CLABSI or a central line bloodstream infection versus a peripheral bloodstream infection and found that to be almost identical. So once it enters the blood, we really are at the same level of risk. And that's why we need to prevent these infections just as importantly as we do in central lines. Now, Staph aureus, of course, well known to be a highly virulent pathogen, very difficult to treat. Research shows that those patients have a higher all-cause mortality, 18% in one study. And the patients that die with this are linked directly to having MRSA, so 3 times the risk if the Staph aureus is multi-resistant. If the patients get inappropriate antibiotics for at least the first 24 hours, that has a 4 times the risk of mortality. And how sick they are at the beginning is also influential. So if they already have sepsis at the time of the blood culture being positive, then there's 14 times the risk of death. Very complicated infections, so those that don't clear after a few days of treatment, those where patients also have a prosthetic device or where the infection has now seeded a distant part of the body, have double the risk of mortality. So the treatment in some patients is very, very challenging. Here's a couple of studies where they've said that the average extra hospitalisation was 3 weeks. 1 in 5 patients were still having positive blood cultures 2 to 3 days later. 15% of patients end up being admitted to ICU because of sepsis and multi-organ failure from their peripheral cannula. And some patients have antibiotic therapy for up to 100 days. This is obviously related to things like metastatic infection, and you can see in the bottom right of the slide that 4% of patients will have a joint infection, but these infections can also end up anywhere in the body once the bacteria enter the blood. So again, although people generally underestimate peripheral cannulas and their risk of infection or think that the infections are just simply treated by removing the cannula, this is not the case. These are very deadly and can be very complex infections to treat. So again, take the PIVC out. If the patient is suspected of infection, we do not wait for confirmation of the blood cultures, we take it out immediately. Of course, we have to consider how sick the patient is at the time to consider the treatment. And we know that failure to treat is a very common phenomenon. In one study by Tatsuno, they said that almost 50% did not get appropriate initial cover, which to start with should generally be empiric therapy, broad spectrum, guided by what organisms you're seeing in your local hospital and what resistances. If the patients are immune suppressed patients, for example, cancer patients and so on, then always consider fungi and other potential unusual organisms. Of course, we need to track the cultures as they come back and adapt the treatment as usual. Here are a few specific guidelines on treating bloodstream infections in these patients. We don't have time to go into this in detail today, but I do encourage you to go and review these excellent resources. So now we've talked about the infectious complications, which are rare but devastating. Let's just have one slide talking about the other things that go wrong, because things go wrong with peripheral cannulas. So, non infectious complications cause the burden of catheter failure. So, just getting the cannulas in or the catheters in is not easy. Many studies show that only about 50% of patients in the inpatient hospital have a single needle stick to put their PIVC in the vein. In the emergency department, this is generally higher because there's a lot more staff that are regularly inserting, better skills, but it is still a problem. Again, I mentioned earlier, patients are older, sicker, and their veins are often in poor condition because of previous IV treatment. In our studies in Australia, we're now seeing that 50 to 70% of patients are what we would call DIVA, difficult IV access, meaning that it is not going to be a simple insertion. Now, why do we care as infection preventionists about this? We care because a difficult insertion is probably going to break a aseptic technique. The inserter gets frustrated, they get anxious, they repalpate areas of skin that they've already decontaminated with antiseptic, and they may reuse equipment. It also means that there's multiple punctures of the skin, so multiple breaks in the skin. Every break is a chance to cause infection. Of course, as healthcare professionals, we care about this anyway because it is very unpleasant for patients. You'll see this poor patient up in the top here. This is unfortunately common that we see in our hospitals where many people have tried to place a cannula and the poor patient just ends up bruised and with bits of tape all over their arms. Now, for post-insertion, even now we've got the catheter in and it's perfect, but they don't last as long as we would like them to. Ideally, the catheter stays comfortable and it stays functional for the several days of therapy that we need to give for this patient. But this is not the case. So, in our systematic reviews, we see 1 in 3 peripheral cannulas fail. So, for some reason, can't be used anymore for the treatment the patient still needs. So phlebitis is really common. So again, pain, swelling, redness, and so on. This can rapidly become severe and intolerable, and we should never be saying to patients, this is normal or you have to put up with it. We know from research we've done that it predicts the failure of the catheter. So even if you ignore the pain, that catheter will fail within 24 hours. The other thing that happens is they become infiltrated, so they move out of the vein and into the tissue, and they may then infuse toxic medications or fluids into the tissue, which can cause severe necrosis and damage. You see this poor baby on the picture there who's had an extravasation and had to have a surgical debridement of that. Catheters are often said to become occluded, which means if the nurse goes up to give the medication and it's blocked or it can't go through. Often this can actually be the phlebitis or infiltration because the vein has just swollen shut internally, and that's why the catheter can no longer be used. Dislodgement happens frequently. Either the catheter comes completely out, it might catch, the tubing catches on the bed rail or gets knocked. Sometimes patients are confused or accidentally pull it out themselves. They can also become partially dislodged. So catheters that are seen leaking, for example, we ideally need 2/3 of that catheter body in the vein so that it stays there and gives the therapy. If you put a short catheter in a deep vein, for example with ultrasound, it's much more likely that if there's only a centimetre or so in the vein, it's going to backtrack and fall into the tissue. Now, regardless of all of these complications, they're a problem. So many patients miss their antibiotic doses or have late antibiotic doses or other therapy because their catheter has failed, and because it's not so easy to get a new one inserted for all the reasons I've mentioned. We know this increases costs and it increases extra insertion procedures and causes a lot of pain and anxiety and workload. So we definitely want to think about improving peripheral IV catheter care, both in terms of infection prevention as well as these other complications. So let's get back to the infections though. So, what can we do to prevent these? We really need to have a range of strategies at the level of the system that we work in, as well as individual interventions at the patient level. We always need to think about our hierarchy of controls. Where can we just take the risk away altogether? What can we put in place to substitute or reduce the risk? And what sort of education and protective equipment and so on can we put in to minimize harm from the risks? Of course, we also need to think about the evidence base, which is constantly changing and growing. And we're looking really for systematic reviews of multiple randomized controlled trials before we really know that a particular intervention has an effect in preventing infection. So, there's two things I think are important in infection prevention. One is to remember that this catheter has a life cycle and we can intervene at any point in this life cycle. So, it starts with the device choice, with the decision to place a PIVC and to use this device instead of other devices or other modes of therapy. We then have the procedure itself, which is a short but very important moment in time. And then we have the maintaining or use phase, which can go over several days or even weeks, where we need to protect the catheter. Finally, we come to the removal and then the post removal. The second important concept is to think about breaking our infection prevention strategies into these two ways: extraluminal protection from the skin, so protecting the outside of the catheter from having bacteria come in along the outside surface, and intraluminally, how do we protect the inside path to stay sterile and to keep patients safe? Of course, our fundamentals are, as usual, hand hygiene. Number one strategy for most things, and absolutely number one strategy to prevent catheter infections. Whose 5 moments of hand hygiene absolutely apply to everything we do with PIVCs. One study that we did in Australia, led by Slater, we observed nurses giving IV medications. We saw that only 11% complied with all 5 moments of hand hygiene. We also saw that in the emergency department, there was worse performance, and also if people were wearing non sterile gloves, they wrongly thought that this meant they didn't need to wash their hands. So, obviously, it's also important for patients to think about hand hygiene while they have a catheter in, because they're touching themselves and the bacteria can get onto the catheter. But we need to, very importantly, constantly check that they're not washing where the dressing is, washing their hands. We see a lot of hand cannulas which are getting splashed while patients are washing their hands. Now, thinking about that initial decision to place a cannula, the only safe PIVC is no PIVC. So, if we can stop clinicians inserting unnecessary devices or just in case devices, we could avoid that risk altogether. Many research studies have shown that a lot of cannulas inserted are never used, particularly in the emergency department. And we shouldn't be placing PIVCs just to take blood. In OMG, 5% were placed only to take blood out of, and that may have been just on one occasion. We need to constantly support staff to think about other alternatives. Oral treatment may be possible, as well as intramuscular and so on. In an emergency, intraosseous devices are now well accepted as an appropriate and rapid way of getting access. So, leaving a peripheral IV in place just because a patient may need it is not acceptable. Some studies have tried and shown the effectiveness of campaigns to reduce unnecessary catheters. This is a randomized study we did, an implementation trial we did in the emergency department, where we just promoted this concept of don't put a cannula in unless you are 80% sure. And we did see that we could avoid 1 in 10 PIVCs being inserted. So, the insertion procedure itself is a very high risk moment in the life of the cannula, and we need to make sure that inserters understand how to do this correctly. Apart from hand hygiene, skin antisepsis is vital. Many studies support the use of chlorhexidine in alcohol as the primary agent. Of course, we do also need to clean the skin first if there's actually dirt on there, and we do need to clip the hair if this is a hairy patient. But chlorhexidine in alcohol should be used unless there is a contraindication, in which case povidone iodine in alcohol is acceptable. There is some talk about should we be moving to sterile glove technique, which of course would have a lot of cost implications, but generally clean sterile gloves are acceptable. However, I do think it's worth considering high risk populations, and in those cases, it may be that a consideration for sterile technique goes ahead. If ultrasound is being used, it should be emphasised that sterile gloves and a sterile procedure should be used. Recent research has shown that low level disinfection of the probe is adequate as long as a probe cover was used and it was not soiled with blood. We want to really avoid inserting over the joint, as I said, because the joint has a higher risk of infection as well as discomfort. So, in adults, let's always go for the forearm if possible. We have to look at who is inserting these cannulas. So in my country, we don't have a high use of IV teams. It's a very high use of registered nurses and junior medical staff. In many countries, it's RN driven. So we do need to think about matching levels of inserter to patient difficulty rather than just attacking every patient and hoping that somebody can get the cannula in. So, a patient that has difficult veins, we shouldn't let our more junior or developing inserters start on them. They should be having an advanced inserter, preferably somebody who can use ultrasound if this is a difficult patient. Many places say you can only have 2 attempts by any clinician and then it should be someone else. But the problem we see is that often the somebody else has exactly the same level of skills. What we really need to reinforce is referring on to somebody with more advanced skills. In medium and large organisations, we absolutely recommend that there are dedicated nurse inserters working in a team and working in a multidisciplinary environment so that they can have better first time insertion success, as well as train and support and assess the other inserters in the institution. In some trials, we've seen amazing differences in the number of patients that successfully get a cannula if we use a dedicated advanced nurse inserter as opposed to just the general workforce. We know that education and training is vital, we also know the workforce is often underprepared for knowledge and skills in this area. The CDC says that everybody who inserts or even cares for a PIVC must have initial training and a competency test. And what needs to be covered is not just procedurally how to get the catheter in, but also infection prevention principles and the bigger picture in terms of what is compatible therapy to go through a peripheral catheter, the documentation that needs doing, appropriate site selection, and so on. Something that often falls down is we need to periodically then give new knowledge and reassessment for inserters, especially those who are not inserting very often. Again, if the institution adopts new equipment, then that would be a time that additional training is needed. We know that with education, we need to have a multimodal approach. So that should include not just theory and practical demonstration, but because the average patient is actually quite difficult, we need to provide some level of mentoring and support as novice inserters start their journey. And as they're doing their first, perhaps 20 or 30 insertions, they may need some guidance and support to develop their skills. Overall, we need to promote this cultural change that a successful insertion is not just getting a catheter in, because a successful insertion is one that is going to keep working and that is going to stay comfortable and is not going to become infected. We've tried putting in some clinical pathways recently, which have been well received to try and support inserters to make a better decision at assessment as to who should have the first attempt to insert this catheter, based not just on the difficulty of the patient, but reflecting on their own skills, and also in pediatrics, looking at some comprehensive things around anxiety, for example. In terms of choosing the site, we've talked already about avoiding placement over joints. I would say that if it's just a procedural cannula, so it's only going to be in place for, say, 4 hours, then this is probably not a concern. But we're really talking about patients that will sleep with the cannula. So patients that have to go overnight, where they're going to be curling up in bed and the IV pump is going to start beeping and alarming if it's in the antecubital fossa. The forearm will give a much more durable cannula, a much more comfortable cannula, because you've got those nice bones there to provide a straight surface. In babies or toddlers that are not yet walking, the lower limbs are also used. As far as equipment, there's a huge amount of equipment available, and we do need to think about what's available in our local context, but also what's safest for the patient. We need to pick a cannula that's long enough to get enough in the vein, but we also need to think about the diameter. So the vessel to the catheter to vessel ratio, we say, should not be more than a third in some studies, or maybe 40%. So this is why, especially with ultrasound, it's good, because we can measure exactly the width of the vessel and think about what size cannula can be fitted in there without causing blood stasis, without irritating the vein. So generally, a smaller catheter in a larger vein is always going to last longer. Ideally, we should be not using needle devices anymore. We'd like to use safety engineered devices with retractable needles so that our staff and patients are safe from needle sticks. We'd like to use catheters that have the blood control feature, that don't allow the blood to flow back and contaminate the environment, and also encourage infection of the cannula. Integrated PIVCs, which have the built-in extension tubing, wings, and so on, we have found that they have a reduction significantly in catheter failure. These ported catheters, like the one in the picture that have a little insertion port on top, these are probably not preferred in terms of it provides an extra place for bacteria to enter. Similarly, with the three-way taps, there's just a lot of openings there. And of course, in general, we only want to use single-use products, never reuse, never share between patients. Gillian Ray Barul did a nice review about the evidence-based bundles for preventing complications in PIVCs. Obviously, we are all familiar with insertion bundles in central lines, which have been very successful in infection prevention. So many people are now thinking, what could we do in peripheral IV cannulas? To date, nobody's come up with a particular bundle, but I encourage you to read that. There are lots and lots of examples out there. Of course, we only really want to have a small number, 3 to 5, perhaps, in strategies. Otherwise, it becomes too difficult for staff to remember and adhere to. But probably, I think this concept of an insertion bundle and then a maintenance bundle is where we need to get to. The things we do every day in the maintenance phase of cannula's life affects their risk of infection. So this is the OMG data. You can see that 21%, or 1 in 5 patients, had a dressing that was dirty, it was wet, or it was loose. So we know from central line studies that this is a risk of infection, and I'm sure it's also a risk of infection in peripheral cannulas. We also saw a very large number of idle or unnecessary cannulas, a large number altogether that either had complications at the insertion site or the catheter itself was malfunctioning. We saw 40% of cannulas did not have the date and time of the cannula insertion documented, and 1/3 did not have any daily assessment of the cannula or any documentation that it had been flushed and therefore functional. So this was a worldwide problem. The rates varied a bit from region to region, but generally there's a lot of process indicators here that are driving a lot of these infection outcomes. So, in terms of noticing this, acting on it, we do need to support our bedside staff better in terms of what they're looking for and communicating that and acting upon their findings. So I decided is a tool that Gillian Ray Barul developed with our team to actually help clinicians to make better decisions. So we're trying to move away from just looking at phlebitis as a monitoring tool because it's not always the only thing that's a problem. You saw those problems about the dressings, for example, and also that none of the current phlebitis tools have actually been fully validated. Whereas I decided now does have excellent information and evidence. You can access it on our website and use it freely available, and it's available in multiple languages. You can see here it guides the clinicians through a decision making process every time they look at the catheter to try and decide if they can take it out and also if it is still working, if it is safe, and to reinforce all the things we want them to do, such as talk to the patient, document, check the infection prevention, and so on. Of course, every day we need to see, is this catheter still working and how can we keep it working? Our research shows that nurses often flush with too much pressure too rapidly, and this inside the vein causes a thrombus to develop about a centimetre from the catheter tip, which probably is then driving a lot of this early failure that we see. So we like to say, don't rush the flush. You can see Sam Keogh's study there down the bottom where she did a large cluster RCT, and by putting in best practice about flushing as well as pre-filled saline syringes, they saw a significant reduction in cannula failure. I put the picture there with the blood in the tubing because we commonly see this, especially in developing countries, because the cannulas are not blood control cannulas. So this is not acceptable. It's an infection risk. It is a risk of the catheter failing. So we really need to be trying to find equipment that we can have where the blood is not leaking back in the tubing, as well as flushing to clear that blood if we see it. Medications, obviously, this is a risk of infection when the medications are given or prepared. It's preferable if they're made in the pharmacy or at the manufacturer, not at the bedside. We absolutely don't want to be sharing vials between patients, and ideally, we would only be using single dose vials or syringes per patient. The infusion tubing, it can generally be left for the life of the catheter unless there is a malfunction or unless we know it's become contaminated. This doesn't apply to bloods or lipids. We still should be changing those every time there's a new bag or a new bottle. And of course, we should be avoiding any disconnection or reconnection of the sets that we don't need to do, because every time we do that, there's a risk that bacteria are going to enter the system. This trial we did was not in peripheral cannulas. Well, it was in peripheral arterial catheters, but also in central lines, where we tested 4 or 7 day routine replacement of the infusion tubing, and we found no difference in infection when they were used for 7 days. Just going back to all this add-on equipment, really have a think about what you're using in your hospital, because the more entry points there are, the more entry points there are for infection. Ideally, we would like to have one lumen and one entry point only for the catheter. Obviously, we do have to think about the patient's treatment and whether that is possible. The other thing we want to look at is hard caps versus needless connectors. So for example, in A and B, we're using these hard caps, which when we open, have an open pathway right through to the bloodstream. Whereas in G, which is one of the many, many needless connectors available on the market, although we inject through this connector, it still has a closed system to keep or reduce the chance of bacteria entering. These connectors sometimes become blocked. So if you think your catheter's blocked, it's often a good idea then to change the connector, because sometimes that's all you need to do to free it up. As I mentioned, we did do a randomized study looking at this catheter in G, this sort of design with the integrated connector and the built-in extension set, which moves the access a little bit further away from the vein and also has a flattened sort of profile that when we sit on the vein, it doesn't create as much pressure. And we did see a significant reduction in complications. Hugely important is decontaminating whatever your injection port is every time the catheter is accessed. Karen Slater looked at the catheter connectors in her hospital and found 50% of them at any point are growing bacteria on the surface, on the injectable surface. So if that is not cleaned off, that is going to be injected into the patient. The technique of scrub the hub really matters. We see people doing a very simple quick wipe and then immediately injecting. That does not give enough time or physical activity to clear the bacteria. There are various options, but we would recommend 70% alcohol wipes as a cheap, effective method that dries very rapidly because we know staff want to get going, they want to give the medication. However, we did do a smaller randomized trial in cancer patients with central lines where we saw adding chlorhexidine to those wipes possibly will further reduce the bloodstream infection risk. So I think more research needs to be done there. I mentioned dressing and securement. Again, many options, many things on the market, but the core principle is we need to get a sterile dressing on these cannulas. In the OMG study, we saw many countries using non-sterile tape directly on the wound, on the open wound of this cannula as their only dressing. I understand there are resource issues. However, the cost of an infection is far outweighed by the cost of a cheap transparent dressing, or indeed sterile gauze is also acceptable. We have undertaken some large studies testing various methods of securing as well as dressing these cannulas, and to date we haven't really found a firm answer, but there are definitely options. So for patients with difficult insertions or ultrasound guided cannulas where you really want to do everything to make this last, we would suggest adding tissue adhesive, just a couple of drops to the insertion site. We've also seen in pediatrics recently this study by Charters, the bottom right-hand side, where this integrated kind of securement dressing had a significantly reduced catheter failure in a pediatric population versus a lot of the other cannulas. Patients and families can also have a huge role in preventing infections. I mentioned that we do need to talk to patients about washing their hands or not washing their hands where the cannula is. So perhaps just using some hand gel, but being very careful to keep it away from the cannula. Also, showering is a risk. So we need to keep that dry. If the patient doesn't know why they have the cannula, the research says there's a much higher chance that that will be left in too long, that it will be idle. And so we really want to encourage every day the patient to ask their nurse or doctor, can my cannula come out today? Can my cannula come out today? We know that patients are reluctant to speak up about problems, so we have to actively ask them and encourage them. And many hospitals are providing excellent flyers or apps or videos to try and help patients to keep themselves safe. Now we're at the end of the catheter life cycle, so just to talk about removal. So removal is actually a very easy and important intervention that we could do to reduce infections. Every single day that patient has a PIVC is a day of risk. So the more days that we are using invasive devices, the more risk. We want to take it out as soon as possible, but we often don't. And this is a picture here, which I'm sure you see in your hospitals, where patients will sometimes have 2 or even 3 PIVCs in place, 2 or even 3 of which have not been used for a day or more, and many of which would not work anyway, even if we tried to use them. They are all a risk. In the OMG study, as I've mentioned, we saw a huge number that staff had not removed, and these were at a time when most hospitals had a routine removal policy, but even then, staff were often not taking the cannula out. So I wanted to just say, what are the good reasons for removal? I think we take it for granted that people know, but they clearly don't know, or we need to provide more training, especially for novice clinicians. So firstly, the treatment is complete. As soon as we don't need that catheter, we can take it out. If it doesn't work, so obviously if it's occluded or it dislodges or it's leaking, we need to take it out. If it's painful, we need to take it out. Even if it's just painful when we inject, we shouldn't be telling the patient this is normal, you have to grit your teeth and get through it. It needs to come out. Of course, if we suspect infection, it needs to come out, and if we know it's been contaminated. So if the insertion procedure was undertaken as an emergency, not in the emergency, but as an emergency, then and we know that the appropriate skin prep or ANTT didn't occur, then we do need to remove that PIVC as soon as possible. So many people ask, should we impose a dwell time? Is there a maximum dwell time? So this is quite an interesting topic that I have been interested in for a long time. So historically, from the 1970s, we did have these time limits for cannulas. Now, bearing in mind, this was back in the day when few patients had PIVCs. Originally, it was designed as a way to prevent phlebitis, or resting the vein was the sort of terminology used. And that was over the years gradually extended as more patients needed PIVCs. Now, people started looking at this. We were still having infections, even though we had this policy. So it wasn't preventing all of the infections. Patients didn't like having new insertions every few days, especially because sometimes that meant 3 or 4 attempts. The nurses and doctors who had to do the insertions were saying, it's much harder for us to find a vein. Why can't we just leave in the cannula that's already working, that is safe? And also, I guess this whole thing gave us a culture where we were complacent. We thought there's only one way to prevent infections, and that's imposing a dwell time. And it kind of meant we didn't think about all the other things that can prevent infections, such as keeping the dressing clean, for example, or using good hand hygiene. So we did a large trial in 2012 where we looked at this question and we tested, should we remove the catheters routinely or not? And we did not find any incidence in risk of infection or phlebitis. Phlebitis was the main outcome of the study. However, because so few infections occur anyway, it is very difficult to test this at this level. However, there's now more than 10 randomized studies in the world summed up in a Cochrane review, and in fact, the bloodstream infection rate is still very, very low, 0.02% clinically indicated and 0.04% with routine. So it doesn't seem like this is an intervention that is going to prevent the infections that we are seeing. Most guidelines now are kind of recommending both approaches. So sometimes they will say clinically indicated removal, sometimes they will say routine removal at a certain time, and they often put a comment there to say this is to be followed if there is not adequate process in the hospital for monitoring and preventing infections. And if there is, then they will recommend clinically indicated. So there's a lot of views about this. There's various studies. Where do I think we are today? Well, I think we're kind of getting to the point where it's almost becoming irrelevant because most catheters fail by day 2 or 3 anyway. So saying that we're going to routinely remove them at 96 hours, unfortunately, most of them have failed by then. We also know that in the clinically indicated trials, it hasn't actually led to a really long dwell time. It's only slightly drawn out, the dwell time. Maybe we should look at routine 120-hour removal because that seems to be the next step in terms of the literature. Interestingly, concerningly, when studies have been done where hospitals have changed from routine removal to clinically indicated, some have reported increased bloodstream infections in their hospital. Some have reported reduced bloodstream infections in their hospital. So this says to us, I think, that it's probably not about the procedure or the policy. It's actually about the underlying standards, the underlying processes of care for insertion and maintenance. And maybe we just need to put all our effort onto that. I do think we do need to think about why don't staff take out cannulas that are clearly problematic or that are clearly not needed, because this is probably our number one low-hanging fruit to reduce risk. So these are the sort of reasons that people tell us why they didn't take out a cannula that's red or painful or that hasn't been used for 2 or 3 days. They say, oh, it's just in case. So that tells us that they have safety concerns. Oh, they might say, I'll get in trouble. I'll get in trouble if I take out the cannula. So that tells us we need to think about the autonomy in the team. Some people misunderstand these routine replacement policies and they say, oh, it has to stay in for 3 or 4 days rather than I have to take it out after 3 or 4 days. Sometimes nurses and doctors, or not even sometimes, often, they don't know their patient has a PIVC because it hasn't been documented, because it's in their elbow under their dressing gown and they haven't looked for it, and because there's no current treatment, nobody's looking for it. The other one is sometimes people say, oh, they don't get infected. We never see any infections. Because the rates are low, people often just aren't aware of the significance. But I think the number one problem we certainly see in our studies is that there aren't enough advanced inserters available to place new cannulas, especially in difficult patients. So staff are very reluctant to pull out a PIVC because they're worried that they won't be able to get a new one in and that they won't be able to get anyone to help them. So I think if we could put our efforts into addressing these issues, this is really where our opportunity to prevent infection is. So, in terms of the big picture, how are we keeping PIVCs safe? There's been some amazing developments in the last few years at a policy level. So, in terms of standards, which are mandatory, Australia was the first country in the world to put out a national minimum standard for peripheral cannula care. There's 10 standards here that all government hospitals have to meet, and private actually, to meet, and they audit it against. I'd encourage you to go to this website, have a look. It's an excellent document, and we were very proud to have input into that. Other bodies, such as the Infusion Nursing Society, have very comprehensive evidence based standards of practice, and the Association for Vascular Access has also recently put out some PIVC specific standards of care. On a world stage, we have wonderful guidelines. Most recently, the WHO have put out some world guidelines on the prevention of BSIs and other infections in intravenous catheters, and strongly recommend you go and review those. A couple of other groups in Europe have also put out PIVC specific guidelines, and of course, there are many other catheter in guidelines which cover central venous catheters as well as have some relevance to peripheral cannulas. Uh, all of that is a lot for your bedside clinicians who are really the ones causing the infection. So these are the ones we try and put at the bedside in this, not sure if you can still see it, but in this monitoring chart, which nurses can use to monitor and respond to catheter issues.
Claire, we seem to have lost your slides.
Oh, let me see if I can find them. Sorry about that. I was nearly on the last one anyway.
You were very close. You were
Just
very
see,
close.
yeah. I'll just see if I can share this again. You can let me know if it works, Paul. Is that good?
Yep.
Okay, great. So this is the I-decided tool, but put into the bedside charting. So we have done away with our old bedside charting that was about, is it red and so on, and it's actually much more structured, encouraging the nurse and the doctor to look every day at these aspects and make a decision. So do they still need it? If not, take it out, and so on. In the future, what will change? Hopefully, we're now seeing a point where the world is coming together and agreeing on strategies to prevent infection in these catheters. And I think we will see more of an equal playing field with peripheral catheters, given as much surveillance and infection prevention as central lines. There is definitely going to be more ultrasound guided insertions and perhaps even sterile glove insertions for traditional catheters. We see more antimicrobial products now being developed, such as dressings and connectors specifically for PIVCs. I do think we need to address our workforce, and maybe infection prevention teams all need an IV therapy nurse specialist within their team to help them keep catheters safe. Perhaps technology, robots, and so on, sensors can overcome a lot of the issues we see in clinical practice. So perhaps they'll do a better job doing insertions. Perhaps they will document more adequately than we do currently. And of course, hopefully, in this very data rich world we will see giving us better information about early infections, about patients at risk, and so on. I've put together just a few of the key references I think are useful if you're looking for some more bedtime reading. And lastly, I'd just like to say thank you, of course, for this opportunity to speak today. And please go to our website and sign up for some updates if you're interested in hearing more about vascular access and infection prevention. Thank you very much.
Thank you, Claire. We'll stay on that last slide for a minute. Thank you for it was a very rich lecture. You have so very much in there, and a lot of, I should say, all of it is very important. Some of it was new information, I think, but certainly you can see how the guidelines are based on a lot of your work. You've done some fascinating work. You very bravely left your email address on that slide, so I presume that invites people to reach out to you if they have questions.
Yes, absolutely. Happy to.
Excellent. I want to point out just one teleclass that's coming up. Now, there are lots and lots of them. There's one on Thursday this week, but next week on Wednesday is the World Health Organization sponsoring a teleclass on the global situation of infection prevention and control and the case for action and investment in improving it. I think that's going to be a really, really interesting talk, especially with a lot of the push to divest in infection control and in developing nations. Lastly, thank you to our patron sponsors, Diversey and Virox and Gamma. Thank you to all of you who have joined us, and Claire, a special thank you to you for being willing and able to present this, both trying to do it last year and doing it this year. Thank you very much for all of that. So to everyone, we will talk to you all again very soon. For now, goodbye.